All right, well, thank you everyone for coming back, and thanks for the great attendance today. So the next session is going to look at therapies beyond immune checkpoint inhibitors. We have a talk on adoptive cell therapy, a couple of talks on adoptive cell therapy, oncolytic viruses, and also other T-cell engager antibody strategies, and then there will be a panel discussion afterwards. My name is Mark Butler. I'm a medical oncologist here at Princess Margaret with a special interest in adoptive cell therapy. So, Yeah, that's what I was pushing. All right, my conflicts of interest are some research support and also advisory boards for industry. So when we think about the immune response, as Dr. Schnoll was reviewing, there are many players involved in anti-cancer effects, and these include the presentation of antigen to the immune system by dendritic cells, then expansion of T cells and other players, which then can traffic back to the tumor and induce a response. The concept of adoptive cell therapy is essentially a numbers game where the idea is that you can infuse large numbers of T cells that are specific to the tumor and then induce an anti-cancer effect. And this may be a way of dealing with the issue of hot versus cold tumors, where anti-PD-1 therapy works very well in patients who have tumors that have already a smoldering immune response, whereas other combination therapies are needed to help drive T cells into the tumor, or if you manufacture T cells or generate T cells through vaccination or radiation, these T cells can then traffic to the tumor and induce a response. Adoptive cell therapy can be divided into three different main types. One is where you take the tumor itself, where you may have a small but ineffective immune response. As Dr. Schnoll pointed out, the PD-1 positive T cells that are present within the tumor can be reactivated with exposure to cytokines. The current strategies used in the clinic for tumor-infiltrating lymphocyte studies expose these T cells to high doses of IL-2. These T cells are then grown to large amounts and then infused as a cell product for patients. The second strategy, which has shown incredible results in childhood leukemias and other B-cell malignancies, is where you take T cells, most usually from peripheral blood, as that's the easiest area to sample, and then engineer the T cell so that it can recognize tumors. So that's literally completely taking potentially a cold tumor and engineering a response that can attack the tumor. And this includes several different types of versions of engineered receptors that can specifically recognize the tumor. And then also there are a series of studies looking at various ways of expanding tumor-specific T cells through in vitro expansion of peripheral blood cells. So for the TIL protocols, there's been a great deal of data produced by Steve Rosenberg at the National Cancer Institute. And over several decades, they worked with adoptive cell therapy, really focused on the idea that the specific T cell response was within the tumor and therefore worked with the technology for expanding tumor-infiltrating lymphocytes. Their initial success was had a breakthrough when several different factors were combined for adoptive cell therapy with TIL, where they highly selected TIL and showed in specificity for the tumor in vitro. These cells were expanded through a rapid expansion protocol so that large numbers of cells, 10 to the 10th, 10 to the 11th cells, could be infused. And then based on animal data, they employed non-myeloablative lymphodepletion as a way to make space for the T cells infused. This results in an increase of availability of important cytokines for the expansion of adoptively transferred cells, reduces regulatory T cells, also causes innate activation through damage to the gut, so you can have activation of the immune system through that mechanism. And then the NCI uses high-dose IL-2, which is part of the standard treatment for melanoma, certainly at the time. And with the NCI's experience, they've, in the pre-PD-1 era, reported that they could have a very high response rate, majority of patients, highly selected groups of patients. But there were many complete responses, and if you achieved a complete response, many of these patients would remain in complete response for decades, and then also a high number of partial remissions as well. So several years ago, the group here at Princess Margaret decided to bring TIL therapy here. It's also been conducted at several other sites, Israel, Europe, MD Anderson, Moffitt. And our program, it uses essentially a very similar strategy that the Rosenberg group has used with a few modifications. We generate TIL from a tumor sample. We undergo what's called a TIL evaluation period where we expand T cells in vitro. We don't do the high selection that the NCI initially did, as it's been found that highly selected TIL are not necessary for immune responses or anti-tumor responses in patients, but instead actually T cells that are more robust and expand quickly is associated more with responses to therapy. Lynn Nguyen in the lab, who heads the group, then takes the cells, expands them through the rapid expansion protocol, and these cells are then infused. Now, one of the modifications that we needed to implement was to use a lower dose of IL-2 in the expansion of these T cells so that we could then treat patients with a lower dose of IL-2 as a strategy for reducing the possibility of life-threatening adverse events that can sometimes be seen with high-dose IL-2. And for the initial study, we've seen clinical responses in patients and have seen some benefit in several patients as well. And here's an example of one of our patients who had lung lesions. He also had groin, subcutaneous, and lymph node lesions. The T-cell product included a predominant VB13.1, a skewing of the repertoire, which presumably includes T cells that are specific for tumor. These cells persisted compared to baseline, such as you can see here with the VB13.1 and expansion of a VB16 TCR. This patient did relatively well for a reasonable period of time. However, he ultimately did relapse, and we found in our patient population, who are almost all pre-treated with anti-PD-1 therapy or CTLA-4, these patients did not have very prolonged progression-free survival, which has been a bit disappointing. It's been quite disappointing for our patients, but we did see that in this particular patient who had a increased engraftment of this VB13.1 population, that these cells expressed a high amount of PD-1 on the cell surface. Patient did not respond to ipilimumab, but then when he was treated with anti-PD-1 therapy, had a dramatic response. He was quite symptomatic at this point, and then had a very nice response to therapy. Patients had a durable response, although we have been dealing with relapse within the brain, highlighting which has been treated with surgery and radiation, but that highlights some of the challenges we have with CNS metastasis in melanoma. We now have a clinical trial that's about to open that we're calling Activate Adoptive Cell Therapy, Invigorated to Augment Tumor Eradication, where patients will receive our adoptive cell therapy and then pembrolizumab afterwards. The melanoma patients will be required to have been previously treated with an anti-PD-1 or anti-PD-L1 therapy, and then we're also have a cohort of patients treated with ovarian cancer that we're planning for this protocol. So in terms of gene-engineered T cells, excuse me, there are two main types. One where the TCR is engineered and then transferred to patients. The TCR, therefore, needs to be HLA matched for patients' HLA. And then also chimeric antibodies are active in the clinic. And essentially, it's very similar to TIL, except instead of taking a tumor, you just take a blood draw, isolate the T cells, then engineer these T cells through various methods, including viral transduction, where the T cell can then express the gene of interest. These cells are expanded. Often products are frozen, and then once the cell product meets specifications for safety, the cell product can be infused into patients. In terms of CAR therapy, there are several generations of CAR T cells, which essentially include the T cell receptor signaling motifs with the specificity of an antibody. And as Pam earlier mentioned, there is been quite a lot of activity in this area with great clinical responses. In terms of ALL, several groups have looked at different CAR constructs and are seeing 70 to 90% overall response rates, many of which can be durable. In adult CLL and other lymphomas, there is active investigation in this area and probably will soon have approvals in the US and Europe. In terms of TCR gene-engineered cells, there's been several strategies that are being investigated. We're working on an approach where we target NY-ESO-1. NY-ESO-1 is a cancer testis antigen that is normally expressed in adult testicular germ cells. It's also expressed in development, but then normal adult tissues do not express NY-ESO-1. This is an antigen that has been described for over a decade. It's immunogenic. Antibodies can develop against NY-ESO-1 and seem to be correlated with better outcomes in some sorts of situations. But it's also aberrantly expressed in various cancers, about on the range of 30 to 40% in melanoma, ovarian cancer, non-small cell lung cancer, bladder cancer, esophageal cancer. It's also highly expressed in synovial sarcoma. There are several companies that are developing TCR strategies to target NY-ESO-1. The NCI group recently updated their data on a trial that was conducted several years ago, where they saw clinical activity in melanoma and synovial sarcoma with the infusion of NY-ESO-1 specific T cells. So we are also conducting a trial here, collaborating with a Japanese biotech company, Takara, to conduct a clinical trial where patients have HLA-A2 positive HLA type, NY-ESO-1 positive tumors, and we're conducting a clinical trial looking at safety, persistence, and anti-tumor response in these patients. There are several other studies that are coming to Canada through collaboration with Adaptimmune, which is a company coming out of Oxford, England. And the studies that we're conducting with them target NY-ESO-1 and also another antigen, MAGE-A10, in looking at patients with melanoma, lung cancer, bladder cancer, head and neck cancer, and ovarian cancer. And then for the expanding tumor-specific T cells for adoptive cell therapy, I thought I'd show you a little bit of data that we generated when I was at the Dana-Farber before coming to Princess Margaret. The strategy here is that these T cell therapies are dependent on specificity, but also the T cell product itself needs to be optimized in a way so that the anti-tumor response can be seen. And we can do lots of experiments showing specificity of a T cell for a tumor target, and end up infusing these cells into patients, and absolutely nothing happens. And the main reason that nothing happens is that T cells don't persist. They may induce a short-term response, but then these sort of overactivated T cells don't engraft and don't persist for a long period of time. There is a series of work that has looked at the concept of infusing less differentiated cells, more memory-like T cells for infusion, and this seems to be associated with better outcomes in patients and certainly in animal models. So Naoto Hirano, who is the next speaker after I speak, and I, when we were at the Farber, developed an artificial antigen presenting cell based on an erythroleukemia cell line K562, where we gene engineered these the artificial APC to express HLA-A2 along with co-stimulatory molecules CD80 and CD83. We then developed an in vitro method for expanding CD8 T cells using low doses of IL-2 and IL-15, many factors lower concentration of cytokine compared to what is needed for generating TIL. And then these antigen-specific T cells could be used for clinical trials. So in our strategy, we targeted MART1, a melanoma differentiated antigen, where we were able to generate T cells after 3 weekly stimulations. So within 3 weeks, we could go from the blood draw of the patient, isolation of CD8 T cells, expand the T cells with the artificial APC, which we radiated so it wouldn't cause any problems for the patient. We were able to generate a polyclonal immune response against this tumor antigen and demonstrated that consistently we had tumor-specific reactivity that we saw in vitro. But what was actually relevant about this strategy is that these T cells weren't over-differentiated, but rather had expression of some memory-like markers rather than full effector T cell markers. And in our clinical trial, we treated about 9 patients with 2 infusions of these T cells. These patients received no lymphodepleting chemotherapy. They received no IL-2 or vaccination following treatment. And then we observed patients for toxicity. The erythroleukemia cell line used to generate the artificial APC theoretically could present stem cell antigens, so we wanted to make sure that the T cell products were safe. In this study, we found that we could increase engraftment of tumor-specific T cells. So compared to baseline, we saw a consistent increase, a number of MART1-specific T cells. And then when you phenotype these T cells, they had a central memory phenotype, which we found could consistently be seen to increase in patient samples post-infusion. And we did actually see To our surprise, a couple of responses just with the infusion of these T cells, a mixed response in one patient, and then another patient had a durable complete response, possibly related to the fact that he had lymph node-only metastasis, and then we infused tumor lymphocytes that probably trafficked through the lymph node. But in any case, it was encouraging that we saw some activity in patients. However, the majority of the patients did progress. This was at the time that ipilimumab was just becoming part of standard of care, and there was an expanded access protocol where patients that had participated in our study were able to participate with ipilimumab. And here's an example of a patient who had very few MART1 T cells detectable at baseline. The patient's infused T cells had a very small but measurable increase in MART1 specific T cells post-infusion. And then the patient received ipilimumab, and at that time maintenance was used after 4 doses of ipilimumab. And a year and a half later, we obtained a sample from the patient and found that 8% of his CD8 T cells were specific for MART1. And when we went backwards and checked for by PCR, we found that some of these T cells, MART1 specific T cells, were present within the graft that we infuse, supporting the concept that we had taken a patient who was naive to MART1, engineered a memory response by infusion, and then allowed ipilimumab to perhaps expand that immune response. In that clinical trial, 5 of the patients went on to receive ipilimumab, and we saw 3 good responses in these patients. So this result for a drug which has a response rate of about 10%, we thought is intriguing. We're now about to conduct a clinical trial where we infuse T cells along with pembrolizumab, where patients get the first dose of pembrolizumab right after the leukapheresis, and then will receive treatment with pembrolizumab thereafter. So in summary, adoptive cell therapy in Canada is an ongoing activity. There actually are several manufacturing facilities in Canada. British Columbia, Montreal have groups that are actively interested in developing TIL therapy and other cell therapy treatments. And while the logistics of cell therapy are challenging, one of the advantages of these therapies is that it's often a one shot and that's it. You don't have to continue therapy. And when you look at the finances, that's not really necessarily that different from a year of pembrolizumab or 4 doses of ipilimumab. In terms of ACT, it is able to engineer an anti-tumor response where there may not be a response at baseline. We were allowed to manipulate the cells in vitro so we can generate the right types of cells for infusion. And we can induce immunity without vaccination, which can sometimes be a challenge in the immune-suppressed host who has a large tumor burden. There are lots of questions that remain. What are the best types of T cells that are needed for transfer? And even despite all of the excitement with CAR T cells, this question remains. And how can we enhance efficacy and reduce toxicity? For the interest of time, we didn't have time to talk about cytokine release syndrome, which is a major issue with CAR T cell therapy. And then I think there's a lot of potential for combinations with immune activating agents such as anti-PD-1 therapies, vaccination, and other strategies for inducing responses that are started with adoptive cell transfer. So with that, I'd like to thank all of my collaborators here at Princess Margaret and also collaborators at the Dana-Farber where we did the artificial APC work. So if anyone has any questions. No questions? Okay.